We begin the examination by inspecting the temporomandibular joint. Place the tips of your index finger just in front of the tragus of each ear and ask the patient to open the mouth. The fingertips should drop into the joint spaces as the mouth opens. Check for the smooth range of the motion. Note any swellings or tenderness. Now palpate the muscles of mastication. Temporal muscles, pterygoid muscles, masseters. Demonstrate opening and closing, protrusion and retraction by jutting the mandible forward and lateral or side to side motion. Start the examination by inspecting the shoulder and the shoulder girdle anteriorly, then the scapula and the related muscles posteriorly. Note any swellings, deformity, muscle atrophy or fasciculations, that is the fine tremors of the muscles or abnormal positioning. Survey the entire upper extremity for the color change, skin alteration or unusual bony contours. Palpating medially at the sternoclavicular joint, start tracing the clavicles laterally with your fingers. From behind, follow the bony spine of the scapula laterally and upward until it becomes the acromion, the summit of the shoulder. From here, palpate the acromioclavicular joint and move your thumb medially and down a short step to the next bony prominence, the coracoid process of the scapula. Grasp the lateral aspect of the humerus to palpate the greater tubercle and the biceps tendon in the intertubercle bicipital groove, checking for the tenderness. Also, lift the humerus posteriorly so you can palpate the subacromial bursae, subdeltoid bursae and the sits muscle, which include supraspinatus, infraspinatus, teres minor and subscapularis. For flexion, instruct the patient to raise their arms in front and over the head. For extension, raise the arm behind. Next, for abduction, raise the arms out to the side and over the head. Adduction, cross the arms in front of the body. For internal rotation, place one hand behind the back and touch the shoulder blade. And for external rotation, raise the arm to the shoulder level, bend the elbow and rotate the forearm towards the ceiling. Crossover or crossed body adduction test. Adduct the patient's arm across the chest. Aptly scratch test asks the patient to touch the opposite scapula in two of the motions shown here. Near impingement sign. Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. For this test, flex the patient's shoulder and elbow to 90 degrees with the palm facing down, then with the one hand on the forearm and one on the arm, rotate the arm internally. Empty can test. Elevate the arms to 90 degrees and internally rotate the arms with the thumbs pointing down as if emptying a can. Ask the patient to resist as you place downward pressure on the arm. This is the drop arm test. Observe the hands in motion for the smooth natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernail edges should be in parallel. Inspect the palmar and the dorsal surfaces of the wrist and the hand carefully for the swellings over the joint or signs of trauma. Note any deformities as well as angulations. Observe the contours of the palm, namely the thenar and the hypothenar eminences. Note any thickening of the flexure tendons or flexure contractures in the fingers. Palpate the 8 carpal bones lying distal to the wrist joint and then each of the 5 metacarpals and the proximal, middle and the distal phalanges. Compress the metacarpophalangeal joint by squeezing the hand from each side between the thumb and the fingers. Note any swelling, bogginess or tenderness. Now palpate the medial and the lateral aspects of each proximal interphalangeal joint between your thumb and the index finger, again checking for the swelling, bogginess, bony enlargement or tenderness. Also examine the distal interphalangeal joints. Palpate the groove of each wrist joint and the anatomical snuff box, which is a hollowed depression just distal to the radial styloid process. With keeping the palms down, point the finger towards the ceiling for the extension, towards the floor for the flexion, away from the midline for the abduction, that is ulnar deviation, and towards the midline for the adduction, that is radial deviation. Instruct the patient to grasp the second and the third finger for the hand grip test. To test the thumb function, ask the patient to grasp the thumb against the palm and then move the wrist towards the midline in the ulnar deviation. To test the thumb abduction, ask the patient to raise the thumb straight up as you apply the downward resistance. Weakness of thumb abduction is the positive test. Tap lightly over the course of the median nerve in the carpal tunnel. Aching and numbness in the median nerve distribution is the positive test. Ask the patient to hold the wrist in flexion for 60 seconds with the elbows fully extended. For inspection, check the alignment and contours of the knees. Observe any atrophy of the quadriceps muscle. Inspect for any loss of the normal hollows around the patella, a sign of swelling in the knee joint and suprapatellar pouch. Note any other swelling in or around the knee. With the knees in flexion, palpate the bony landmarks, the muscles, tendons, and the ligaments. Pay special attention to any areas of tenderness. Pain is more common complaint in knee problems, and localizing the structure causing pain is important for accurate evaluation. Palpate the tibiofemoral joint. Identify the groove of the tibiofemoral joint. Follow it medially, then laterally. Note any irregular bony ridges along the joint margins. Palpate the medial meniscus. Press on the medial soft tissue depression along the upper edge of the tibial plateau with the tibia slightly internally rotated. Place the knee in slight flexion. Also palpate the lateral meniscus along the lateral joint line. Apply pressure on the suprapatellar pouch, displacing or milking the fluid downwards. Stroke downwards on the medial aspect of the knee and apply pressure to force fluid into the lateral area. Place the thumb and index finger of your right hand on each side of the patella with the left hand. Compress the suprapatellar pouch against the femur. To assess large effusions, you can also compress the suprapatellar pouch and ballot or push the patella sharply against the femur. Watch for the fluid returning to the suprapatellar pouch. With the patient supine, grasp the heel and flex the knee. Cup your other hand over the knee joint with the fingers and thumb along the medial joint line. A palpable click or pop along the medial or lateral joint line is positive test. Move the thigh along the 30-degree laterally to the side of the table. Place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. For this test, push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. Pain or a gap in the lateral joint line points in the positive test for the lateral collateral ligament. Cup your hands around the knee with the thumbs on the medial and the lateral joint line and the fingers on the medial and the lateral insertions of the hamstrings. Draw the tibia forward and observe if it slides forward from under the femur. Position the patient and place your hands in the position described for the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur. Place the knee in 15 degree of flexion and external rotation. Grasp the distal femur on the lateral side and the proximal tibia on the medial side. Simultaneously pull the tibia forward and the femur back.